This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
Our penultimate speaker is Associate Professor Michael O'Leary. He's a Senior Specialist in the Intensive Care Unit working in Sydney. He's Co-Director of the New South Wales Organ and Tissue Authority and a past President of ANZICS. The title is Life After Death, but if you read a little bit further, you'll notice this is not about what happens after we die, and it's not really, I don't think, going to be a heavily religious talk. It's more going to be about the prognostication in cardiac arrest. So an area which I must say causes myself and my colleagues in the ICU a great deal of angst, and so I'm very much looking forward to this. Thank you.
Thanks very much. Okay, so life after death. The problem is that up to 80% of people who survive a cardiac arrest in the community and get transported to hospital will remain comatose. And if you look at patients from countries where there is not a tradition of withdrawing life support in intensive care units, a significant proportion of these patients will eventually develop a persistent vegetative state. So I think most of us would agree that withdrawing life-sustaining therapy is a broadly acceptable thing to do for appropriate patients with appalling prognosis. The issue is when to do this, and there's an argument to suggest that we want to try and prognosticate early, if possible, prior to having to make a decision about things such as tracheostomy that would mandate a more prolonged period of support. And there may be, for many patients, a window of opportunity to withdraw treatment. And if we miss that, we could condemn people to a very unpleasant ongoing life. And also now, of course, with the increasing emphasis on organ donation after circulatory death, we need a level of prognostic certainty when we go to families to recommend withdrawal of treatment, because the last thing we want is for a patient not to die in the time frame for DCD and then subsequently a couple of weeks later to take his organs home with him as he is discharged very well from hospital. So prognostication has always been difficult, and I think many believe that it's possibly more difficult nowadays, especially in the era of targeted temperature management and perhaps improvements in supportive care. So we need prognostic markers with a high sensitivity to aid appropriate decision making, and this really means to have things which would have a false positive rate of around 0. Now, traditionally, simple clinical examination has been the mainstay of prognostication, and it's been recommended for many, many years that this is that we wait before making a clinical prognostic judgment for 72 hours. And at that stage, if you have absent pupils or corneal responses or a Glasgow Coma Score motor response that's extensor or worse, so that's 2 or less, that these are good reasons to withdraw treatment. But the problem is that many patients do not have absent corneals or pupillary responses at this time. An earlier prognostication, really the only thing that I think most people seem to agree on was that if you had a myoclonic status, even in the first 24 hours, you could withdraw treatment. And in certain centres, the use of bilateral somatosensory evoked potentials with bilateral absence of the N20 peak has been considered to be useful in prognostication. The problem with assessing reliability of prognostication is that it's very, very difficult. So, and the main problem is this one of the self-fulfilling prophecy. So the presence of the prognosticant allows you to withdraw treatment and then the patient dies and you say, well, there you go, and that was right then, wasn't it? And most of the studies that have looked at this have really failed to account for confounders, so the effects of sedation and organ dysfunction. And also the possibility that the patient may have non-convulsive status epilepticus. It hasn't been my practice, for example, to do EEGs routinely on patients after out-of-hospital cardiac arrest. And the use of early hypothermia in management certainly has, according to case report at least, made this more difficult. And there have been a number of reports of quite delayed neurological recovery in patients who've had hypothermia, including a case of a patient who apparently was brain dead and then appeared to recover from a clinical diagnosis of brain death. So recently, I think we've been helped by the publication only last month of this paper from the targeted temperature management team in Scandinavia, who looked at the impact of the two different temperature management regimens in that study on their ability to prognosticate in the patients. And the most important thing really was that there was no difference in inability to prognosticate despite the different temperature group that you were allocated to. But importantly, in this study, the prognostication was very carefully defined, and the decisions were made after 72 hours following rewarming by clinicians who were blinded to the patient's temperature group assessment. The assessment was made after the patient sedation had been ceased, although it wasn't clear how long it was left to see if the sedation had worn off, or what assessment was made to see if sedation may not be still causing a problem with assessment. And it was essentially a clinical judgment with the Glasgow Coma Motor Score, pupils and corneals, the use of somatosensory evoked potentials where available, and EEG to exclude status epilepticus. Earlier prognostication was allowed if patients were comatose and had significant myoclonus in the first 24 hours, and in addition had absent SSEPs after rewarming. So 37% of the patients actually did undergo early prognostication, and half of them had their treatment withdrawn earlier than 72 hours, and that was 20% of the entire cohort. And another 15% of the entire cohort of patients died from either cardiovascular or neurological complications prior to the 72-hour after rewarming assessment. And what they found, looking at the ability of the different tests to determine prognosis, was that the Glasgow Coma Motor Score was very poor on its own in determining outcome, with a 14% false positive rate and a confidence interval that included 50%. So you could say that in half of the time when you'd get an absent a motor score of extensor or worse, you'd actually have a chance of doing well. Pupils and corneals were really very, very sensitive in predicting patients who were going to do badly. But the problem was, as I said before, that they were quite rare. One patient with absent pupils and one with absent corneals did well, but no patient who had both absent did well. And somatosensory evoked potentials were very good at predicting a poor outcome. So if you had bilateral absence of the N20 peak, the confidence interval for that being a false positive was only 13% maximum. And in fact, there was only one case where a patient did well who had bilateral absence, and they think that was due to a technical problem with the test. So what about neuroimaging? Well, CT scanning, as we know, is frequently normal if it's performed very early on post-cardiac arrest. And it's often worthwhile waiting 48 hours and repeating the CT scan to see evidence of ischemic damage. But there's no relationship between the findings on CT scan and outcome that have been published, and guidelines from different societies across the world, none recommend the use of CT scanning. And similarly with MRI, although you may see differences earlier on, you probably won't, there's no evidence that this helps you with prognostication. And EEG, although it's not imaging, I think there's now a really good suggestion that EEG should be routine in assessing patients post-cardiac arrest who remain comatose, to exclude the possibility that they have status. So in summary, prognostication is best done with a delayed multimodal approach, and certainly should not be done until at least 72 hours following rewarming. And interestingly, in the TTM study, the average time to prognostication was 117 hours, which is actually about 5 days following cardiac arrest. It's important to exclude the effects of sedation and non-convulsive status. And in patients with myoclonic status, it may be important to give a muscle relaxant so that you can get a true representative EEG. If you're worried about the effects of ongoing sedation, it's quite appropriate to give reversal drugs where available. The Glasgow Coma Score motor response is very poor on alone as a prognosticant. Pupils and corneals are good but occur rarely. The SSEPs are very good but are not available everywhere, and they do require some technical expertise. And imaging and biomarkers remain unproven. Unfortunately, most guidelines, I think, fail to address the most important factor that you can use in making a prognostic decision, and that's to evaluate these findings in the setting of the patient's premorbid status, their current organ dysfunction, and any known care preferences that they may have, for example, if they have an advance directive or if they've spoken with family members about their wishes should they have a catastrophic event such as an out-of-hospital cardiac arrest. Thanks very much.